Hi, everybody. Thank you for the kind invitation to talk about the pharmacokinetics of long-acting cabotegravir. These are my disclosures. So what are we going to talk about today? We're going to look at what it means having to deal with a long-acting drug and why we should prescribe long-acting drugs and whether the concentrations are the same for everybody, whether we should worry about the pharmacokinetic tail, and then we're going to briefly look at drug-drug interactions involving long-acting drugs. So a long-acting drug is a drug that is slowly absorbed and slowly excreted, and it persists in the circulation and tissues and is effective over a long period of time. And the prerequisite of a long-acting drug is that it is administered less frequently. Once a week, once a month, every other month, every 6 months, or even more than 6 months. And interestingly and importantly, it provides increased choice, increased convenience and health privacy, and it simplifies adherence. And it reduces the amount of the active administered drug sometimes. This slide shows the concentrations of a long-acting drug compared to what happens to the concentrations of a orally daily administered drug. You can see that we don't really change the main pharmacokinetic concepts. We need to achieve concentrations that are above the minimum effective concentrations and are effective for prevention. We need to make sure that the maximum concentrations is not above the toxicity threshold. And you can see that there is a clear effective range of concentrations. And when I say effective in this context, it's obviously effective for HIV prevention. So what about cabotegravir long-acting? This slide shows the history of its development. It was obviously studied first preclinically in primates, and it showed that it protects macaques from intrarectal sieve infection. Preclinical studies are followed by phase 1 studies. Phase 1 study shows that the concentrations achieved in plasma persist for prolonged periods of times, and also tissue concentrations were measured in people without HIV. Phase 2 studies were very important to establish the dose and the dose frequency for cabotegravir PrEP. Today, cabotegravir PrEP is used every other month. And then large phase 3 studies were presented over the past few months and showed that cabotegravir was able to prevent HIV infection. The HPTN-083 and HPTN-084 studies provide very solid pharmacokinetic data. The HIV incidence rate in 083 was remarkably lower than the incidence rate for Truvada and FTC, for tenofovir and FTC taken orally. Interestingly, however, there were 4 infections that occurred despite continuous cabotegravir long-acting treatment and despite the achievement of protective drug concentrations. Was this because there was not enough drug in compartments? Or it's because of the viral load in these people was so high that the concentrations achieved weren't enough to prevent the infection? Hopefully, we'll have these answers soon. Similarly, there were 1 to 2 infections in the breakthrough infection in the HPTN-084, which was conducted globally in women to prevent HIV infection. HPTN-083 also looked at transgender women, and the ethnicity distribution in both studies was very wide. So both studies, I believe, are very informative. So let's talk a little bit about cabotegravir population PK. Population PK is useful to characterize the pharmacokinetics of the drug and determine factors that influence parameter variability and drug exposure. It can also help to optimize dosing strategies. Interestingly, there are some factors that influence the pharmacokinetic parameters of cabotegravir long-acting, and these are gender and BMI. So a typical female has a slower absorption rate and a longer persistence of cabotegravir in the body. And also, while accounting for gender, larger BMI causes a modest decrease in absorption rate compared with smaller BMI. However, the magnitude of change in absorption of cabotegravir did not alter its trough concentrations to a clinically significant decrease. So that is why these factors don't affect cabotegravir too much, and cabotegravir C-trough remain appropriate for efficacy in preventing HIV infection. They achieve level well above the effective established targets. However, there's still some outstanding issues when we plan to use cabotegravir long-acting. We need data in girls younger than 18 years. We need data during pregnancy and breastfeeding. We need to know whether cabotegravir is present in the milk and what are the concentrations of cabotegravir in the milk. There are still some real-world implementation issues and strategies to optimize adherence to appointments need to be implemented. And also there are concerns about the pharmacokinetic tail. Briefly, what do we mean for pharmacokinetic tail? So these are the concentrations of cabotegravir that would be achieved if someone who is administered cabotegravir for PrEP doesn't show up at his next dose appointment. These concentrations will inevitably achieve suboptimal levels. And we know from data in primates that if this is the case, there is a risk for resistance development. These graphs show that when the concentrations of cabotegravir decrease, these are indicated in pink, the viral replication restarts, this is indicated in blue, and when the viral replication restarts, mutations that confer resistance to the integrase inhibitors class are developed. Therefore, it is important to introduce the use of cabotegravir long-acting as a strategy and introduce the concept of oral bridging strategies so that if someone is not able to show up at the next appointment for his injections, we can bridge with oral drug to ensure that these low and risky concentrations are not achieved. Briefly, what about drug-drug interactions for long-acting drugs? Because these drugs are not administered orally, the likelihood for drug-drug interactions to occur at the level of the gastrointestinal tract is 0, which is very good news because we will have to face a lower risk for drug-drug interactions in general. However, let's not forget that there still could be drug-drug interactions that are clinically significant. So if we co-administer strong UGT1A1, which is the main metabolic pathway for cabotegravir metabolism, induces, like rifampicin, the risk for cabotegravir concentrations to be remarkably decreased and ineffective is there. In conclusion, we know that people prefer long-acting in treatment trials. What about prevention trials? You can see here the results from patient-reported outcomes from HPTN 077. And you can see how many people actually expressed the wish to be on cabotegravir long-acting to prevent HIV infection. So what are the take-home message? Well, there are definitely exciting developments with injectables and implants and other long-acting formulation. We need to learn about the PK tail. We need to learn about different population exposures, bridging strategies. We need to be very comfortable with all of that to advise our patients on what is best to do while they are on cabotegravir long-acting PrEP. Obviously, the issue about drug-drug interactions remains, but we are avoiding all of the gastrointestinal tract drug-drug interactions. And we're up for implementation challenges, and obviously we need data during pregnancy. Thank you very much for your attention.